We are back, and I hope everyone has had the opportunity to sort of tour their way through the virtual booths that we have. A lot of information, a lot of good resources, and we are going to keep the booth open for about a half hour after we end today, so then you still have an opportunity to go and to visit and to get more information, to get more resources that will be very, very helpful as we then, sort of deal with this opioid epidemic within this pandemic. Welcome back. Everybody has their coffee or their we had Sprite. We had Sprite that was introduced here today. So thank you guys for all of that. Lawrence Kenyatta, thank you so much for your passion. Thank you for being the boots on the ground, everything that we need. And so as you can see, this whole issue of prevention, everybody has a hand in being able to make a difference in our barbershops and in our beauty shops. We change the world. So with that, addictive behavior is what we've been talking about. And that part of that addictive behavior that we are so much aware of and that has loom large in our community is gambling. So we are going to bring on a panel of experts, and I'm going to introduce them right before each of them are brought on to sort of give their talks. And I want to start with Lori Mello. And Lori is currently the program manager of HMSA's Gambling Treatment Program. She was formerly the manager of clinical best practices training and treatment innovations for about 4.5 years. Prior to the training and treatment innovations, Lori worked as the community education coordinator at Haven, an agency that deals with domestic violence and sexual assault. She has also worked in fundraising and campaigns at the United Way, served as Associate Director of Women's Survival Center in Pontiac, and did extensive case management in Detroit and in Oakland County at Caregivers. There she worked with and supervised teams that work with at-risk families and youth, providing in-home counseling and support services. Lori holds an undergraduate degree in social work from San Diego State University, a graduate degree in counseling from Oakland University, and a graduate degree in public administration also from Oakland University. Lori, you're up next.
Thank you. Thank you very much. That was an introduction. Sometimes I don't know what I've done half the time. It's like there's so much there. But thank you. It's nice to hear. Welcome to Friday. Hello, everyone. Welcome to Friday. How exciting, even if it is Friday the 13th. I would like to begin by talking a little bit about gambling disorder and how gambling disorder is coexisting with substance abuse in particular, as well as other mental health diagnoses. I think there's a lot of clinicians who have some understanding of gambling disorder, and that's great. However, there's some things that you may or may not be aware of. I'd like to point some of those out and some of the similarities and differences between substance use disorder and gambling disorder. What I have up here first is our Gambling Disorder Treatment and Prevention Program helpline. This is available 24/7, 365 days a year. There is always a live person on that line to speak with someone if they just want to talk about their gambling issues, if they want to get an assessment done and referred to a counselor on our panel, our statewide panel, they can do that as well. We also do crisis intervention. We have a lot of people calling us as well who have suicidal ideations. There's a lot of things going on with our gamblers, some of which are not necessarily evident right at the outset, right at the very beginning. So that's our helpline, 1-800-270-7117. And this is just a little bit about what we do on that line. As I said, we do a comprehensive screening. We are funded by the Michigan Department of Health and Human Services. We have treatment referrals, information referrals, so we can refer to other places like financial counseling, legal counseling. We are not financial counseling. We are not attorneys, but we can refer for other resources. We also do referrals to Gamblers Anonymous and Gamma Non. We are not affiliated with Gamblers Anonymous. However, we do have some information we can provide to them, and also crisis intervention And certainly we do a lot of crisis intervention. We also have a speakers bureau where we can go to different community groups, churches, schools, anywhere where it's needed, anywhere where somebody wants to know a little bit more about gambling disorder and some of the issues surrounding gambling disorder. So right away, what is gambling? This is the formal definition of gambling. It's any betting or wagering for self or others, if it's for money or not. And basically, it's where the outcome is uncertain and it depends on chance or skill. Some of the skill is a bit dubious. We talk about games of skill. Sometimes the gambler will tell you that this is a game of skill, and it's just a matter of what I do and how I work the cards, or how the kinds of bets that I make. There's still a lot of chance, no matter what you're doing in terms of gambling. It's to risk money or at times something of value. So it doesn't necessarily have to be money. And we need to understand it's not all about the money with gambling. Types of gambling that are available, certainly you see everything here listed on the slide. There's some things there that may surprise people as well. There's a wide range of ways to gamble. In the state of Michigan, we have about 28 casinos in the state alone. About 10 of those casinos are in the UP. And gambling isn't thought of the way it used to be, where it's mainly men, kind of the guy who goes to the racetrack and does gambling and with the cigar and everything. It's not like that anymore. Certainly we still have those types of gamblers. But as far as men and women, for example, calling the helpline to get services and so forth, it's about equal. We have male and female gamblers alike. Even things like bingo is considered gambling. Internet games and things, that's how a lot of the youth get started. And youth are at great risk because they start off and there's a lot of gaming that goes on the internet now, social media, and it starts off as free, and before you know it, they're paying money to play these games. So the gambling diagnosis has really evolved. We still, in certain times, we call it problem gambling. You may have heard that term. It's really talking about a person whose problems, there's some problems in their life due to gambling. However, these people are not at the brink where their home is being foreclosed on, and they're getting a divorce. The children aren't speaking to them anymore. It hasn't gone that far yet. But there's some problems. There's some issues with I couldn't make my rent or my mortgage payment last month, so I had to transfer some funds from my savings. Okay, that's one thing. But it starts to spiral downward. This used to be a popular term, pathological gambling. As a matter of fact, that's how it was referred to in the DSM-4. It was the clinical term at the time under impulse control disorders. Fortunately, the diagnosis was changed in May of 2013 when we came out with the DSM-5. Under the DSM-5, it was put under substance-related and addictive disorders, which is, I believe, professionally, where it belongs. It certainly is an addictive disorder, and as you will see shortly, there are some interesting things about that. And then here's a little bit of statistics on the prevalence of gambling disorder. The reasons why people gamble, there's a lot of reasons why. I think a lot of us have gambled before, but here's my red flags where it starts to get scary. Any of these, attempt to feel better or escape or to feel important, and then finally that inability to stop. There are social gamblers. Those are the majority of us. There are problem gamblers. As I said, problems are starting to, increase debt and cause problems in the family, but it hasn't reached this. Major life problems, major life issues related to their gambling activity. Two styles of gamblers. There's the risk taker or the rush gamblers. Traditionally, that has been men, but many women are on board with this now. And then the escape people. So a lot of times more females than males, and a lot of senior citizens are doing the escape gambling. So our role really as a helper or a professional is to say, not necessarily do you gamble, but what kinds of activities do you participate in? and how often and for what duration. Because we don't want to think of a gambler who is addicted as someone who goes twice a year to celebrate someone's birthday at an office party, and they go and maybe they play. But how often are you doing this? Are you just in a pool in the office, like once every few months? Or is it something of great regularity? These activities, as I like to call them, have they caused problems or issues in your life? And namely these. So you can ask the questions, these kinds of questions. Have you ever sold anything to finance your activity? Um, did it make you careless of the welfare of your family or yourself? Have you ever played to escape worry or trouble? That's a big red flag. Have you ever thought about committing illegal acts? Have you ever had difficulty in sleeping? Lots of times people have difficulty in sleeping, and they'll come to us as clinicians and they'll say, I have insomnia, for example, and we think maybe it's depression, and maybe it is, but you have to ask the question about the gambling as well. Any of these kinds of things. You feel like celebrating, or to get over a disappointment, do you feel like going to gamble? Any of those kinds of questions. Understand this is a hidden addiction. So there's no substance ingested, there's no visible signs. So many of our clients could be gambling, and if we don't ask the question, and let's say they go in for a substance use disorder referral or something to do with their mental health challenge, we need to be asking this question because there could be contributing factors associated with gambling and gambling disorder. Typically, individuals who come to you for active gambling problems, they come in for gambling problems, they're not seeking help for the gambling. They don't see that as the problem very often. They're coming in because they're feeling blue, they're feeling down, very nervous, sleep disturbances, and so forth. So they don't, as I said, see or conceptualize gambling as the part of the problem, but sometimes it's part of the solution. And the challenge is that gambling can both relieve and contribute to depression, and certainly to any kinds of problems. Because what happens is they're up one day and they're winning, and they say, I don't have a gambling problem, I have a money problem. And then what happens is they come down and they lose a lot of money, and that's very often when they call our helpline as well. So there's a lot tied into the self-esteem with the winning and losing. Remember, it's never really about the money, it's about how they feel when they're winning. The other thing that's hard in treatment is it's hard to prevent relapse because gambling is so normalized in our society, and it's everywhere. So it's in the casinos, it's in your stores, different places where you might go. It's in the bars, pull tabs, Keno, any of that stuff. There's so many games, and of course, your phone is the new casino. The smartphone is your new casino. Certainly. Some similarities and differences between gambling disorder and substance abuse or substance use disorder. Lying. Some of the similarities is lying. So lying to support the fact that they're using, that they're going to the casino, that they're doing whatever, they're playing these games. And a lot of the teenagers are playing games on their phone while they're in class, because so much is available. I must see one or two commercials every day talking about a casino on your phone. That's become very commonplace. If you look at any of these similarities, and those of you who have a lot of experience with substance use disorder, I know you can see this. The withdrawal symptoms are very common, even physical withdrawal symptoms. The comorbidity issue, they can cross addictions. Very often they may go into treatment for 28 days or or 60 days for alcoholism, for example. They get clean, they're in recovery, and months later, they're into gambling. And that's not something that's thought of as an addiction right off the top. So what happens is people think that, oh, that's very normal. That's an outlet. Typically having low frustration and tolerance for frustration and coping skills, and they're using the gambling as a coping mechanism, as they would drinking, as they would drugging, using opioids, anything like that. The difference is typically gambling is an invisible disorder. It's very hard to see it on a person's face. You can't really see it on the way they carry themselves very often. There's no substance ingested. And here's the main thing that's different. There's no chemical overdose with gambling. So they can gamble and gamble and gamble. I know people that have spent upwards of $2 million in casinos, and they have to wake up in the morning. It's not like, I mean, if you did that many drugs or if you drank that much, you may be deceased. But with the gambling, what happens is there's no saturation point. So it's very hard to treat. You've got to ask the questions because you can't necessarily see it. You can't smell it on their breath. The other thing, too, is the unpredictability of the gambling activity. So what happens is somebody is gambling and they are, as I said before, winning. And then all of a sudden they start losing. So it's like when they're winning, there's no problem. It's up and down constantly looking substance use disorder for a way to satisfy that urge and that craving. And that's where, chasing their losses, running after money to go to gamble more. And that could include illegal acts. It could include stealing, borrowing, or legal borrowing or illegal borrowing from family and friends. It could include a lot of different things. But the denial is really what's very, very pervasive with gambling disorder. And the perception by the general public is that it's not necessarily a disorder or an addiction. We have to get out of that mindset and realize this can coexist with a substance, or it can or a mental health challenge, or it can be another addiction that happens after they get over the initial one. Other differences, the financial crisis that we hear about all the time, very likely for the gambler. And then the other thing is becoming a success, the fantasy of I'm going to be a professional gambler. I've worked with people with substance use disorder over the past many years, and I don't recall ever hearing anybody saying, I want to be a professional drinker. I mean, that's obviously that just doesn't happen. But with gambling, certainly, they see that as almost a career path. So there's a difference when you're treating people with gambling disorder. Very high suicide attempt rate with gamblers. I want to say that very clearly. One of the highest rates of suicide is among this addicted population. Very high suicide rate. And there's fewer treatment options available, fewer Gamblers Anonymous meetings than there are AA or NA. So at this point in time, and this is changing, there's no residential treatment in these states, but it is changing in Michigan. And we have some colleagues and friends out there who are helping us to kind of get the residential treatment together. But at this point, too, a lot of prevention programs, there's just being developed now. We are growing and things are changing with that. But so some of the differences, the options are not as great for gamblers. And then the family impact as well. Family impact, it's felt very, very strongly in the family finances. People in the family who have never taken charge of the family finances are finding that they're having to do that. I want to be respectful of the panel members, my other colleagues, and their time on the panel. Here is once again our helpline, contact information. Anyone who is interested can certainly contact this line for more information about what we do. I'm happy to avail myself as well to any questions. Thank you.
Lori, thank you very much. A lot of good information, a lot of those aha moments as this addictive behavior is so prevalent in our community. I would like to now, our next panelist is David Sampson, and he is the CEO of Mariners Inn, a shelter and treatment center for homeless men in Detroit. Mr. Sampson earned his BSW at University of Detroit Mercy and his MSW at Wayne State University. Yay! He is also a graduate of Northwestern Kellogg School of Nonprofit Executive Management, and he has previously held positions at New Era Alternative Treatment Center, Highland Park High School, Wolverine Human Services, the Children's Center, my old alma mater, and his own private practice. David has been the Mariners Inn since 2002. He has been a mentor to the men of Mariners Inn by providing mental and spiritual support during times of need and change. So with that, let's welcome David Sampson. How are you, sir?
I'm doing well, Dr. Deli. Thank you so much for that wonderful introduction. I appreciate it.
Good.
So I really want to thank the Greater Detroit Area Health Council and Detroit Wayne Integrated Health Network for allowing me a couple of minutes to talk about the importance of recovery as relates to mental illness and substance use disorder. So let's just dive right into it. I want to really talk about a system that I think is so relevant and needed in this area of recovery, and that is the recovery-oriented system of care. I want to talk about the positive impact of peer and recovery housing support services. So I'll do that by giving a couple of definitions and then diving into some key points. The clinical definition of addiction is a chronic relapse disorder characterized by compulsive drug seeking, continued use despite harmful consequences, and long-lasting changes in the brain. It is considered both a complex brain disorder and a mental illness. So the definition of recovery has been identified as a primary goal for behavioral health care. Sampson has developed a working definition and set of principles for recovery. A standard unified working definition will help advance recovery opportunities for all Americans and help to clarify these concepts for peers, families, funders, providers, and others. Sampson's definition of recovery came about in 2010 after leaders in the behavioral health field, consisting of people in recovery from mental health and substance use problems, and SAMHSA met to explore the development of a common unified working definition of recovery, which is a one-liner and very simple and complex in the same context. Recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. So how does ROS play a role in that? The definition of the recovery-oriented system of care is the central focus of ROS is to create an infrastructure or system of care with the resources to effectively address the full range of substance use problems within communities. A ROS is a coordinated network of community-based services and supports that is person-centered and builds on the strengths and resiliencies of individuals, families, and communities to achieve abstinence and improved health, wellness, and quality of life for those with or at risk of alcohol and drug problems. I'm trying to forward to the next slide here. So what do we know about recovery? Stable alcoholism recovery is not reached until 4 to 5 years of sustained remission, even longer for other drugs. Short periods of abstinence are really periods of brief dormancy and not sustained recovery. Recovery can be initiated in an artificial environment, but successful recovery maintenance can only be achieved in a natural community environment. Now, I don't want to misconstrue the word artificial environment in this context. What that is really referring to is acute care, a temporary environment where it's a short residential stay or a short outpatient stay, but it's considered artificial because it won't be long-term. Post-discharge continuing care enhances recovery outcomes, but only 1 in 5 people receive such care. That care consists of recovery support services, where there's peer coaching, peer mentoring, recovery housing, family reunification, case management that includes health, education, employment, and it can involve criminal justice intervention. So what does ROS provide in that respect? The recovery-oriented system of care supports the provision of peer support services delivered by people who have been successful in the treatment and recovery process themselves. It is my firm empirical, professional, and personal belief that peer recovery support services and recovery housing are essential elements to ensure the type of long-term sobriety necessary in helping to rebuild communities that have been devastated by the disease of addiction. A person's substance-related issues cannot be treated apart from addressing the needs of the whole person in the context of his or her environment. Recovery housing is one of those necessarily relevant needs by people in recovery and one of our most essential services. Recovery housing allows us to provide person-centered, consumer-driven, and ongoing recovery support services for individuals as an integral part of the treatment process during the post-acute stages of recovery. Research has proven that individuals living in appropriate housing designed to promote health, wellness, and long-term abstinence are more likely to be successful. Recovery housing is given high priority as a treatment intervention because it ensures that a proper transition to community reintegration can be experienced by the people we serve. Now, aside from the very important and traditional roof over someone's head, recovery housing provides the type of case management services that help to alleviate the anxiety associated with premature community reintegration and include vocational counseling, individual help and group therapy, leisure activities, and the coping skills necessary to move into independent community living on a long-term basis while preparing for long-term sobriety. But what are some of the positive individual outcomes of RUST? Abstinence, education, employment, reduced criminal justice involvement, stability in housing, improved health, social connectedness, and quality of life. Now, I want to really hone in on the social connectedness part of this individual outcome because I've heard it mentioned in other presentations before this one that is such an important element in helping on the successful track to recovery. People really understand and promote and admire when you connect with them individually, and they really care more about how much you care versus how much you know. So social connectedness is really important as a positive individual outcome of RUST. Now, the positive system outcomes expand services options beyond acute care, extends client engagement into the community, normalizes the recovery process like other diseases, for example, diabetes, cost effective, and it has real world application of living skills. Now, I want to leave you with these few words before I turn it back over to Dr. Dudley. If we truly believed addiction was a chronic disorder, we would not expect full recovery is always achieved from just one treatment experience. We would not discharge people from services because they show symptoms of their disease. I'm going to read that one again. We would not discharge people from services because they show symptoms of their disease. I've been around long enough to know or to have experienced and have seen where people are actually held accountable from a punitive standpoint for the very disease that they sought treatment for. In other words, there was an old mantra, you use, you lose, which I am so glad that people have evolved from because we need to treat people better. We would not think a brief intervention is all that's needed. If we truly believed addiction was a chronic disorder, we would think of recovery support services as essential elements of a lifelong process. We would view recovery as a lifelong process. We would avoid punitive actions when clients show symptoms of their disease. And we would understand that treatment is a small part of the recovery process. Thank you, and I'll turn it back over to Dr. Dudley.
Mr. Sampson, thank you so much. And I know you've been that mainstay in the community. I've been at Mariners Inn, and we just applaud the work that you're doing on behalf of all of the constituents that we serve. So thank you. Now I wanted to bring up our last presenter, and is Dr. Brad Ray. Dr. Ray joined Wayne State University School of Social Work as an associate professor and director of the Center for Behavioral Health and Justice in 2019. Dr. Ray received his PhD from North Carolina State University in sociology in 2012 and spent 7 years IUPUI, where he served as a research director at the Indiana University Public Policy Institute. He is a community engaged researcher, which is awesome, that focuses on mental health and substance use, particularly where those populations intersect with the criminal justice system. Much of his recent research has focused on evaluating policies and interventions aimed at the recent overdose epidemic and translating evidence-based harm reduction strategies into practice. Without further ado, Dr. Ray, welcome.
Hello, can you hear me okay?
We can hear you just fine. How are you doing?
Very good. Thank you for having me.
Good.
Can you see my screen all right? Are folks able to see my screen? I'm going to take that as a yes. Let me double check. Yes, okay. Thanks for having me today, everybody. So what I'm going to be talking about is one of the most pressing public health crises of our time, and this is the overdose epidemic. And it is largely driven by gaps in treatment. So I want to start out by talking about where we are nationally with the overdose epidemic, talk about some of the community engaged research that my team and I have done to illuminate this, and then just get into some of the evidence-based practices that we think could address this social problem. So just as a bit of a backdrop so everybody knows, in the US, accidental drug overdose deaths have been increasing exponentially for the past 40 years. In 2016, they actually surpassed motor vehicle deaths as the leading cause of accidental death in the United States. But over the past 20 years, we've seen this shift in the types of substances that people are dying from. For those of you that might not know this, prescription opioids, heroin, and fentanyl are all part of the same underlying classification of drugs, opioids, right? But you can see over time, those substances have shifted in their prevalence in overdose deaths. So about 20 years ago, this epidemic was driven by prescription opioids. About a decade later, as those prescriptions became, those pain analgesics became more difficult to obtain, individuals moved over to heroin. And then we see the third wave occurred, and it depended on where you were nationally, but the third wave being fentanyl. An illicitly produced opioid that is much more powerful than anything that had come before. And in that fourth wave, that most recent wave, what we've been seeing is a co-use of illicit stimulants, that would be methamphetamine and cocaine, along with illicit opioids like fentanyl. But on the right there, you can see the substances that are most frequently detected in overdose deaths are fentanyl, followed by those illicit stimulants, then heroin, and then prescription opioids. And I tell folks this just so that they can see that this has shifted from becoming a prescription opioid problem to a largely illicit opioid problem. So as I said, for the past 40 years, we've seen an increase in overdose deaths in the United States. 2018, which is the year which national data are most recently available for, was the first year in over 40 years that there was ever a decrease in overdose deaths. It has been an exponential increase. However, importantly and sadly, this reduction was only experienced amongst white Americans in the United States. We still saw increases in overdose deaths amongst African Americans, particularly in urban areas. So I want to talk a little bit about, I want to get into some of the research that we've done, my team and I've done, and I thank you for pointing out that I spent those 7 years at Indianapolis, because that's where a lot of this data is going to come from. Unfortunately, it's proven a little bit more difficult to get this information here than I anticipated. But I want to show you one of the things at first that a lot of people don't think about is that all overdose deaths, almost all, 95% or more, are what we refer to as substance use deaths. So there's multiple substances detected in the post-mortem toxicology result. And we've created these network figures to illustrate those connections. So you can see this is the key over here on the side. And as the prevalence between substances becomes greater, the line gets thicker. So you can see amongst white decedents between 2011 and 2014, this very strong prevalence of prescription opioids and benzodiazepines. But you can see in those, let me go back here. In those years, in these years between 2011 and 2014, amongst African American decedents, you see a strong prevalence between cocaine and heroin, right? That you don't see amongst the white decedents. But when we look at this post-fentanyl phase, what we see here is this line between cocaine and cocaine and heroin starts to diminish, and we see this line between cocaine and fentanyl beginning to get increased. So what we're seeing is this increased prevalence of cocaine and fentanyl and overdose deaths amongst African Americans. So one of the things you might see in media reports or in social media stuff out there is this idea that these substances are being adulterated. And sometimes that information comes about because people look at the postmortem toxicology results, they see marijuana and they see fentanyl, and they make an assumption that marijuana must have been laced with fentanyl. We've seen similar claims of meth and cocaine across the country. So from February of 2019 through February 2020, we conducted a project in Indianapolis where at the scene of accidental drug overdose deaths, rather than destroy the substances that are found there, which is what was normally done, we obtained a DEA license, collected all of those substances, sent them to Notre Dame University, where we tested them on a mass spectrometer. And what we did is we wanted to look at those overdose deaths where we saw a combination of illicit opioids, so heroin or fentanyl, and illicit stimulants, methamphetamine and cocaine, and ask the question, can we find at the scene of these deaths those substances combined or adulterated? And the short answer is no, we did not. We did not find those substances combined or contaminated. And instead, what we often found, which we consistently found, were those substances separated. We found fentanyl and we found cocaine. We found fentanyl and we found meth. What we did find, and we think helps explain some of those earlier figures I showed, is that there really is no such thing as heroin anymore. 95% of the heroin that we tested had detections of fentanyl in it. The last community engaged study I want to tell you all about is something we've just recently completed, and give just a little bit of a background. In 2019, this study came out in JAMA, which suggested that as law enforcement seizures of fentanyl increased across the state of Ohio, they were suggesting this causal relationship that as those seizures were occurring, police, law enforcement seizures of fentanyl, that it was actually increasing overdose deaths. And so just to tell you a little bit about the mechanism of why folks think this is happening is, if you've developed an opioid dependence, you're purchasing substances from the same person for a consistent period of time, you at least learn to trust what that substance is, how much of it you can consume to obtain the feelings that you're hoping for from it, right? If that individual is removed, if you have an opioid dependence, you have a matter of hours before you're going to go into very painful withdrawal, which can lead to chaotic drug use, mixing drugs, trying new substances, and thus increasing the risk for overdose. But we were very unsatisfied with this kind of year analysis. So what we did instead was, over the same 5 periods, we obtained data at the street level of all opioid seizures when law enforcement seized opioid. There were 6,201 of these. These varied in size between pounds and bags. Then we also obtained the fatal overdose data, where exactly fatal overdose deaths occurred, but also non-fatal overdose events where naloxone was used, administered to reverse an opioid-related overdose death. And what we found is, first off, unequivocally, we've done all additional analysis to show that as police seize opioids, then there is an increase in non-fatal opioid-related events, a 12 to 18% increase in those events. And we see it occurs in kind of a ripple effect, where early on, at about 3 days after the event and 100 meters out, we see this increase being very significant, noted by the darker red here. But then over time, once we look at 21 days out, the effect is strongest at 250 or 500 meters out. So suggesting that further away from those seizures, people might be running, they might end their supply within 2 weeks or so, which might cause those overdoses. What we did not find was a significant impact on those fatal overdose events. It was on those non-fatal events. So just wanted to give you a sense of some of the research that we do to try and understand this epidemic better. Now I just want to shift over to talking about some of the treatment for opioid use disorder. As Dave had talked about, and I won't get into this too much, opioid use disorder is a brain disorder. Here are the DSM criteria for determining an opioid use disorder. And again, many of these, as we talked about before, not all of them are about sort of tolerance and withdrawal. Many of them are about these social factors that play into this disorder. But the research is very clear in showing that the most effective treatment for opioid use disorder are medications for opioid use disorder. There are 3 FDA-approved medications, buprenorphine, methadone, and naltrexone. You may know naltrexone by its name Vivitrol. You may know buprenorphine by its name Suboxone, but these are the 3 FDA-approved medications. Research tells us that individuals who engage in these medications are more likely to reduce drug use, reduce risky behaviors and criminal behaviors, and have greater benefits than those who do not. I will tell you the recent comparative effectiveness studies suggest that buprenorphine and methadone have some of the most salient effects. Particularly buprenorphine, we see as an effective substance in other places for reducing overdose. So I'll tell you that I had seen this article back in 2007. I've been in this opioid overdose epidemic thing for a while. And in 2007 in France, they had started to provide buprenorphine pretty easily so that general practitioners could prescribe it. It could be dispensed through the pharmacies and really treating it almost like an antibiotic in a way. And what they saw were significant decreases in heroin and overdose deaths declining by 80%. Meanwhile, in the US, the recent secret shopper studies where they call providers to see if individuals can get buprenorphine are suggesting that, only 25% of facilities even have this gold standard treatment for opioid use disorder, and many places try and actively discourage individuals from taking this because of the stigma around these medications. When we have these treatment gaps, one of the main evidence-based practices that we always suggest is naloxone. Totally non-addictive substance, easily administered to reverse an opioid overdose. It's been in EMS since the 1970s. More recently, there's efforts to get it into the hands of other first responders and laypersons. I think the U.S. has done a pretty good job of getting naloxone out there. I do think it should be available over the counter. I wish it was, but we do need to do more targeted efforts to make sure that we're getting naloxone into the hands of those individuals who are most likely to use it. And one of the ways that I think we can do that is by more readily embracing harm reduction. So harm reduction is a philosophy. It's a philosophy when we can't get individuals to change a potentially harmful behavior. How do we get them to reduce the amount of harm for it? Every time you get into a car, you are putting your life at risk to drive when you drive that car. However, hopefully you practice the harm reduction of putting on your seatbelt, wearing a helmet when you're riding a motorcycle, wearing a life jacket when you're out on a boat, sunscreen, getting flu shots. These are all examples of harm reduction. But when we think about harm reduction actually going into action, like people going in the street and doing it as a policy or a program, there's no harm reduction program that has ever been more effective than syringe service programs. This is where I got my start doing this type of research, volunteering at one of these programs. And it's the most effective form of harm reduction for persons who use drugs. I say this, that there are only 320 syringe service programs in the United States. We need many more of these programs. And since their inception, since they've been around, they're constantly a source of misinformation, where individuals believe that syringe service programs will increase drug use or crime. And the empirical evidence could not be more clear. Syringe service programs, folks that engage in these are more likely to enter into treatment. They're more likely to reduce their drug use. There's no observed increase in crime. And in fact, the studies show us that these are where you put syringe service programs, you're actually going to see decreases in those discarded syringes. So very cost-effective program, very important evidence-based way for us to potentially reduce the number of accidental overdose deaths in our society. At an individual level, I always tell people if they're looking for things they can do, I think the number one thing we can all do is take a moment to question our own stigma around opioid use disorder, substance use disorder, and addiction more generally. One of the reasons that we're continuing to see these deaths increase in our society is because of stigma. We know the paths forward. We know the way to solve some of these problems, and we simply are not able to do it because our stigma gets in the way. So I think that's one of the things that at an individual level, I think we can all focus on. But that is the last slide I had, so I'll stop sharing and turn it back over to the panel.
Wow, Dr. Ray, data. Wow, this is extremely impressive. All my panelists are back and ready for my slew of questions that I have for you. Lori, you started out, so I'm going to start with you. With job loss and feeling no way out, are we seeing an increase in this gambling behavior?
It's a good question. I think we're seeing.
Okay, you're on mute.
Okay.
No, she's not. Okay.
No. Can you hear me now?
All right.
Okay. It's a very good question because, well, when we were in lockdown, when the COVID situation, kind of reared its ugly head in March, we saw actually a decrease to calls to the helpline. That doesn't mean we're not seeing an increase in gambling. I think what's happening, though, is the gambling activity is shifting. When the casinos weren't open, people shifted their gambling to online gambling, if they could buy lottery tickets, whatever was available to them. So there's a bit of an increase, but a lot of it is shifting different types of gambling.
Also, unfortunately, back before COVID hit, and I think even now with some of the casinos opening back up and advertising, hey, we're open and ready for business, just socially distanced, we'll go every other slot machine. Um, some of these establishments, some of the gambling establishments are targeting our seniors. You mentioned that briefly in your presentation, but not only are they targeting the seniors, they're offering rides to the casinos
Oh, yeah.
and rides home and that kind of thing. What do you think we can do to one help deal with this, but then help to address our seniors about some of the dangers of being picked up and dropped off?
Yeah, and you're absolutely right. And it's even more than just offering them a ride. They very often offer them coupons for lunch, free a certain amount of chips to go to the casino and actually play. They give them part of their casino card is prescription discounts on their prescriptions. So they really have a good read on that demographic. I think education is really the key. Understanding, helping the seniors and people in their assisted living homes and places who work with them, helping them to understand education and awareness of the dangers. That we're not against all gambling, but the fact that the house always has the advantage, and to make them understand too that let's talk about other ways in which you can spend your time. And you're talking about people who are very lonely. They're going through a lot of grief very often. So getting them to understand that there's other options, other ways out there, and exactly what's going on with the gambling and why they're being pretty much targeted is very helpful.
A question from our audience. Lori, is there a harm reduction component to gambling?
We have used in the past harm reduction with some of our clients. What we find is a lot of times people will come into treatment, and that's a way to get them into treatment, to be inviting, warm and welcoming, so to speak, because very often people are very scared. They're very afraid to make that change. It's a great change to stop gambling. That's a lifestyle change like any other. And so what we do is we might bring them in to decrease their gambling, to see if they can handle that. We develop a plan with them about how they're going to decrease their gambling. Very often we get them into treatment that way. And then what we find is the client understands, you know what, I can't do this. I have to be abstinent. I've tried this, and for me, this just isn't working the way I want it to work. And so we go forward with abstinence, but we may start off that way. But yes, we do harm reduction all the time.
Awesome. Mr. Sampson, yesterday we heard information, especially in Florida, about the housing that some of folks who may have addiction disorder are being exposed to. How important is housing? You mentioned it already, but how important is it for us and for these individuals? And are you seeing some of the same kinds of misuse and the targeting and the predators that are preying on our population when they go to seek services and then they go into this housing?
Yeah. Thank you for the question, Dr. Dudley. And it is absolutely imperative. And I'd add a couple of words to housing. Affordable housing, housing that's that people can actually afford, and if it's in an environment that's conducive to success and long-term sobriety, and where other people within that environment are seeking the same goals, makes it that much more important. But it's unfortunate that people who don't have access to resources, or who may not have the education or the employment background necessary to secure housing that could be considered safe and reliable, are taken advantage of. I've seen a couple of reports just recently where some landlords have pretended like it was their property, but because a person didn't understand what they were signing or what they were getting into, were signing on the dotted line to someone else's property and ended up being evicted. And those don't always have to have issues of substance abuse and homelessness related to them, but just the very predatory nature of someone doing that to people who are less fortunate does happen in this field. But it's really important that housing is affordable, that services are accessible and that people have a common focus in that environment.
Thank you for that. You talked about recovery-oriented system of care. How does this force us to see addictive behavior along a continuum?
Yeah, because you're treating the whole person. I think it's so important when you think about a network of supports and services related to helping someone recover, that it takes an all hands on deck approach. And a recovery oriented systems of care provides for the person does have their own individualized plan of treatment and recovery, but it takes many resources and many pathways to help them reach their goal. And when they're placed into a sort of it's a term they used to use a long time ago, and sometimes they still do, a wraparound environment where everyone has decided to join in and help this person recover and regain their dignity and respect. It meets the needs of the recovery oriented system approach of helping the person recover. So it's extremely important.
Thank you for that. Dr. Ray, one of our viewers wrote, she says, I'm curious if you found any barriers to MAT access for parolees and probationers due to drug testing during your research on OUDs and criminal justice. Does MAT medication show up as positive for opioids in urine tests?
Yes, those medications would show up in urine tests. And so what was the first part of that question?
They are curious if, have you found any barriers to MAT access for parolees and probationers due to drug testing?
It's not just due to drug testing. So to be clear, one way to think about it is we have a problem in our society at large where we don't have enough providers that are actively dispensing these medications. Now, the problem becomes more salient when you move into these justice populations because they're at such high risk for death, especially following release from jail. It's that same mechanism that we were talking about with dealers as well. Somebody goes into a facility, people rapidly cycle through jails. By the time they leave, they believe they can take the same amount of the substance they were before. They cannot, they don't have that same dependency, and then they experience an overdose. People are at 120 times more likely to die of an overdose when they leave a jail than the general population. An overdose is actually the leading cause of death amongst returning inmates in our society. So there's a lot of work that needs to be done, probation, parole, community supervision inside the facilities to both engage people into treatment, to create a continuity of care for individuals who go through these, but to also inform, educate, and address the attitudes that we sometimes see, the stigma that we sometimes see around these medications in those agencies and those roles as well.
Why do we see that increase in death for parolees? Is it due to possibly going back to a level of use that they did before they were arrested?
Yeah, and it wouldn't just be parolees. Just think of somebody, taking a certain amount of substance. They go into the jail. They go through rapid withdrawal, painful withdrawal. They're out of that jail within, oftentimes 48 hours, back on the street. They received zero treatment while they were in jail. No one screened them for having a disorder. No one told them that they had a disorder. No one routed them into care. So that individual walks out of that facility with an opioid use disorder, thinking very clearly that they want to get rid of these feelings that they're having, knowing that opioids can do that. They consume those substances at the same levels that they were before potentially, and their body can no longer tolerate it, and then they experience that overdose once they're released.
Wow. One other question is, with some of these MAT drugs, do they help to ease the discomfort of withdrawal when getting off the different opioids?
Absolutely. Yes, buprenorphine in particular can help to reduce some of those withdrawal symptoms.
I think you may have answered this, but the question is fentanyl mainly found mixed with heroin, marijuana, and prescription medications?
We only find heroin. And again, I say this because it was only in Indianapolis for 1 year. I would love to replicate this study in Detroit. But in Indianapolis, we found essentially there is no such thing as heroin anymore. All of the heroin is cut or mixed somehow with fentanyl. And I know a lot of people want to think about this as like people kind of maliciously doing this stuff, but this is not Breaking Bad. These folks don't have labs. A lot of times it's, a magic bullet or bowls that are being used. So fentanyl is such a powerful substance. I will say very powerful, but also you cannot overdose from being in a room with fentanyl. You have to consume it. That is a big myth that people have out there. But what we did not find was fentanyl combined with any other substance, cocaine, meth, marijuana, nothing like that.
And that was just based on that one study there. Are you planning to replicate it here?
I would love to. If anybody can help us out to get that done, do not hesitate to contact me.
One, out here on the field, that's the data that we need.
I will say I think it should be a regular part of the death investigation process and frankly, law enforcement seizure process, that these drugs should all be tested, whether or not they're going to trial to determine what's there.
Lori, I don't know if you can answer this particular question. Do any of the addiction related medications work for gambling addiction?
I'm not aware of that. I know there are some things that are being tried, but I can't say with any specificity or good knowledge that any of those are being used for gambling addiction.
Doc, do you know?
I do not know of any, no.
All right. Mr. Sampson, do you have any recommendations for organizations who wish to collaborate with others to set up a recovery-oriented system of care?
Yes, I think one of the most important aspects of any agency that's in the field that we're in, substance abuse treatment and recovery, you can rely heavily on the people that have successfully gone through your program. We like to consider that as part of our program, the alumni that have successfully completed, who are now peer coaches and peer mentors. If you are a program that has that set up and you know a program that doesn't, I would recommend connecting with that program and finding out what the positive aspects and criteria of what those services mean, what the peer coaches and the peer mentors and alumni guys mean to the people that are coming into treatment and the people that are leaving treatment. But we are open to providing our expertise in that area and helping people to set up, those types of programs in their agencies if they so choose to do that.
Dr. Ray, one of the things that we're finding on the ground here, we've partnership with University of Michigan and HIDA, and we get real-time data on overdoses and deaths. And we looked at that with our coalition in our zip codes. And one of the things we found is that those overdoses and deaths are really impacting 55-year and over African-American males. How do you suggest we address this?
Fentanyl testing strips through harm reduction agencies so that individuals can test these substances to be cautious of what they might be consuming. I also think having more culturally tailored syringe service programs specifically towards populations where we're seeing these types of deaths, especially in Detroit. I think those are kind of the two big ones that come off the top of my head to address this.
One of the things that when we're talking about prevention, I mean, the best image I had was you go upstream and you find out who's throwing our kids, our families, our patients in the water in the first place. So when we look at prevention, I know you said that, the chart that you showed with regard to those folks who were prescribed opioids and the relationship between that and ongoing addiction. But how do we then introduce the alternatives to opioids for acute pain management, both to our physician population as well as to the patients?
And this is kind of a big sociological answer here, but one of the issues with the United States is we continually are focused on the substance of the year, the substance of the decade. It's slowly shifting now from opioids to the concern around meth. Back before opioids, it was cocaine or crack cocaine. We need to shift away from talking about specific substances and talk more generally about substance use disorder and the causal factors for substance use disorder, things like childhood trauma and events like that. So until, as a society, we can really just focus on the disorder of substance use and rather the kind of demonizing the substance of the year, I don't think we're going to be able to adequately do some of the prevention work that we want to do.
All right, this is a challenge for the three of you. You're going to have about 30 seconds each to wrap up in 3 words, a takeaway. All right, Lori.
Okay. Education and awareness is the key for gambling disorder and understanding it. I know that's more than 3 words.
That certainly is more than 3 words, but absolutely welcome. All right, Dave.
Recovery is real.
I like it. Dot.
Every single overdose death is a policy failure.
It looks like, thank you for that. It looks like prison reform and looking at, because many of some of the inmates were arrested for substance use and placed in prison versus, getting treatment. They're released in other ways. And so with everybody in our audience that's out there, one of the things that we're looking at is how do we advocate? How do we understand the issues that are not the drug of the day? And how do we sort of make our voices heard that these are the ways in which we can create a or a system that is oriented toward care so that we can create harm reduction and that we can look at some of the challenges our community is facing and work hard to make a difference. So, what was that?
Sorry, that's my dog.
Oh, it's the dogs. Who let the dogs out? All right. Well, thank you very much, and thank you so much. We are going to have the PowerPoints that were shared. They're going to be up so our folks that are viewing us will be able to have access to. And then guess what, guys? We have your email addresses and phone numbers, so look for calls. So thank you so much for your time and also for that incredible information.
Thanks for having us.
Thank you.